Well, no, great to see you, and thanks so much for joining us. Let me get started and ask you, when were you first exposed to echo? What do you remember?
I remember actually being totally hooked on echo when I was a cardiology fellow. I was at the Toronto General Hospital. Harry Rakowski, whom I know you know well, was then the director of the echo lab. And this was at a time that we were transitioning from M mode to 2D.
Sure.
And I'm sure I annoyed at least the lead sonographer, who was very patient, but when I was on call, I used to just take the then new 2D echo machine and try to echo the patients in the CCU and elsewhere. Rarely made a correct diagnosis, but I thought it was a pretty cool technique, and didn't have any sense of where it was going to go particularly, but thought it was a keeper.
So that was during your fellowship, and then how did you further that interest in echo as it plays a role in cardiology?
Well, the way it turned out, and again, Harry Rakowski figures strongly in this story, Toronto at that time had an academic affiliation of sorts with Stanford, and so I was signed up to go to do what in essence was going to be a hybrid between exercise physiology and sports medicine at Stanford. And Harry, God bless him, pulled me aside and said, you seem to enjoy echocardiography, and I know Ned Wayman, another well-known figure, who at the time had just moved from Indiana University to MGH. And he said, Ned, I believe, is looking for advanced fellows. I know him, would be happy to put in a good word. He did, and I was able to switch fellowships, if you like, with another fellow who was very interested in going to Stanford. She went into my place and I went to Boston. So that's how it all played out.
And what sort of, as you developed, your interest and your certain expertise in echo, back at that period of time, would you ever have envisioned it being where it is today?
I would not have, although I did appreciate that there was nothing like it in terms of imaging, but more importantly, a tool for understanding the physiology of the heart. Maybe not necessarily coronary vascular biology, but what I call the big stuff, the muscle, the valves, the pericardium. This was at a time when much of the focus of cardiology was on coronary interventions. But I felt that, I knew for me, that wasn't what was so interesting to me, and that there were probably others like me. So I felt that it was going to be very important as a research tool. I don't think I totally appreciated how invaluable it would become as a clinical tool.
Did at Ned's lab and Ned's operation in Massachusetts, obviously he had a tremendous research bent.
He did.
Okay. But there were also some, and I've touched upon this with some others earlier, there were also some really unique sonographers. So this whole concept of the role of the sonographer in the development of the field of echo, sort of what's your thoughts on that?
Well, I believe then, and I still believe that sonographers are probably the most important piece of doing echocardiography well. The MGH lab at the time, and actually continues to be, led by a superb sonographer, Jane Marshall, whom I'm happy to give credit to for really having taught me how to scan, how to do echocardiography, and more importantly, how to set standards high. Not to settle for okay pictures when you could get really good pictures, not to settle for fuzzy pictures when, by turning the patient, sometimes it seemed on top of their heads, you could find some window somewhere that showed the heart well.
So, and I would agree wholeheartedly with you on that. Linda, the echo, sort of when transesophageal echo came along, it sort of migrated into the operating room. And in your position now, you're certainly intimately involved with the whole field of valvular diseases and anatomy and all that. What do you see the role of echo being now to the surgeon, to the interventionalist as we move into the era of interventional valve procedures? What's your reflection on that?
Echocardiography is absolutely key. And I think if I look back, what's happened with fellowship training is that virtually all fellows now have a reasonable understanding of what they look at, what they're looking at when they look at an echocardiogram. Virtually all of the surgeons have a pretty good idea of what they're looking at, and of course we have 3D now, which makes it easier to understand what's on the screen. The current generation of interventionalists, who I believe will be the group who will make transcatheter valve therapies their own, really do have an appreciation for echocardiography. Many of them know how to scan to some degree. They're more adept at adapting to intracardiac echo than I would say were the interventionalists of my era, many of whom had gotten through fellowship, spending a lot of time in the cath lab, but virtually no time in the echo lab.
And you're exactly right. It's not only valves; it's ASD closures and all the things that I didn't envision. I think you're exactly right. You, how did you get involved with the American Society of Echo?
Again, Ned's name comes up. I had left MGH by this point and was in Connecticut, and was interested in what were the beginnings of the quality movement in echocardiography and in broader terms, advocacy. And Ned appointed me to initially the writing group that Joe Kislow chaired, that developed one of the earliest position papers related to echocardiography, quality in echocardiography. And from there, I was appointed to the advocacy committee. So that's kind of how I got started.
And you were the 15th president of the American Society of Echo, the second woman president.
That's right.
Is that right? What do you remember about your presidency, or do you remember? I mean, I've asked some people, and I don't remember anything.
I remember that it was, without a doubt, the most enjoyable year professionally of my life. Busy, needless to say. But I had kind of moved up the ladder, starting with not an official ladder, but had gotten some exposure at least to the executive committee by serving as treasurer and simultaneously scientific programs chair. The year that the SARS epidemic came up in Toronto. So I knew that having dealt with what was absolutely a last-minute move that translated to a remarkably successful meeting, I knew the caliber of ASE staff, who were enormously helpful, and I also knew what a wonderful resource the past presidents would be. Again, Harry's name comes up as someone who made a big difference in making that whole move possible. And of course, Pam was president at the time, and she was very much and continues to be a very take charge, let's just get the job done sort of person. Right. So I knew I would have help when I started, and that turned out to be something that I was right on. The things that I remember the most about the year, and I guess I'd like to think the ways in which I made some impact on the organization. I carried out the strategic plan, which updated ASE's goals, mission, and although there's been some modification since, pretty much the goals that we set at that time remain the goals for the organization. I instituted what was at the time the spring retreat, with the idea that our committees would be more effective if they met earlier in the year, not simply in June, where they would go home and probably have a great summer, and then when they came back, have forgotten largely what their committee was supposed to get done. And the last thing I implemented was a planning meeting in the early summer, essentially right after this meeting will conclude, to plan next year's meeting, so that the planning would get done earlier. The planning would get done in a way that would make it easier for more people to participate. That was the first year that it was set up to be a standalone face-to-face meeting of the program committee.
What, as you reflect back on the American Society of Echo, so you've served in various great roles and done a super job, what do you see its role in today's complex field of medicine for the echo community and really for cardiology?
I think the American Society of Echocardiography is the major voice for quality in imaging generally, but obviously ultrasound in particular. Everything it does, I think, can be taken back to that element of its mission. I think that echocardiography has, through technical advances, moved to be a tool that people who arguably aren't as well trained as might be ideal use. I think that with pressure on echo labs for time reductions, increased output, there's pressure on sonographers to do more, not necessarily doing it well. And I think the American Society of Echocardiography has provided the tools for sonographers, fellows, graduated physicians in anesthesiology, in cardiology, in radiology for that matter, to do echocardiography well. And along with that, it's advocated for the sorts of quality, formal quality initiatives that are increasingly playing on center stage. In healthcare reform, it's advocated for the sorts of resources that echocardiography labs need to do their job well. Without the American Society of Echocardiography, I would be concerned about the quality of echocardiography if I looked forward to, say, year 2025.
Right. One of the excellent points. What do you see if you look back? So look back on your career now as a user of echo and somebody who's obviously very knowledgeable about it. What do you see as some of its contributions to our, diagnosis or management of disease?
Well, you can almost start from the outside of the heart and move in. But I'm actually going to start with coronary disease, even though I said that echocardiography, at least mainstream echocardiography, doesn't really look directly at the coronary arteries. But that said, we look at regional wall motion. We look at all of the other complications of coronary disease. We look indirectly at coronary anatomy because we have perfusion agents now. So we can look at perfusion with intravascular ultrasound. We actually can look directly at the coronary arteries, and I would submit getting better anatomic information than we do with angiography. My area of interest is really what's now termed structural heart disease. There is nothing out there that elucidates valvular anatomy and physiology better than echocardiography. Ischemic mitral regurgitation, which is a professional interest of mine, is something where the pathophysiology has been elucidated almost 100% by people who would call themselves echocardiographers. Pericardial disease, again, constriction, tamponade, those are all things where echo doesn't just show the anatomy, it's helped us really understand the physiology. Great vessels. It's the whole. It just keeps going. The whole cardiovascular system. I don't think that there is an imaging modality that comes close to echocardiography in terms of what it's brought to our understanding of cardiovascular physiology and pathology, and contributed as much as echocardiography has in the day-to-day management of patients.
If you, which you do, I'm sure, if you were standing in front of some cardiology fellows, male, female, and sort of giving them some advice, what would you tell them about the future of echo? Or the future of imaging, but really the future of echo?
I would tell them that echocardiography has a bright future, that it will remain the primary imaging modality for specialists in heart disease, that it will probably benefit from increasing scrutiny on things like radiation exposure, real dollar cost of providing testing. That said, I would probably encourage cardiology fellows who were not destined to become full-time academic imagers to learn how to use other imaging modalities as well. I actually think there's cross-fertilization. I think that people whose roots are in nuclear perfusion imaging actually find it easier to read stress or resting perfusion echocardiograms. And finally, I would encourage people who are looking for an academic pursuit to select an area where the focus wouldn't be exclusively the technical elements of echocardiography or any other imaging modality for that matter, but where echocardiography can be enormously helpful in understanding pathophysiology. And that would probably, and probably has been, my spiel to the fellows I've tried to recruit into making valvular heart disease their career-long objective.
My final question would really, and you've already touched upon it, but just to go back over it again, where do you see the future of the American Society of Echo being? You know, we're through at this meeting that we're recording this at, we're going to crown our 21st president. So it's a robust organization. Where do you see it going in the future?
I think the American Society of Echo will continue to grow in terms of numbers. I think it will continue to grow in terms of the scope of its programs, and I would say particularly in the field of quality improvement. I mean, we're seeing new metrics out of the National Quality Forum for imaging. The American Society of Echocardiography, I think, is going to be at the forefront of a lot of this activity. I think it will remain an inclusive organization. They may have some uphill battles in terms of supporting its sonographers, who I think will be under increasing pressure to maintain quality and, for that matter, their involvement in the society. But if I look forward, I see ASE's future as being strong, not without challenge, but bright.
Super. Listen, I really appreciate you spending the time. You've done and all that you've done for the field and for the society. Thank you very much.
Thank you. It's been great.
Good.